Hello, everyone, and welcome. I'm excited to be here today to talk about triglyceride-induced acute pancreatitis. On this first slide, you'll see the title of our presentation. We'll be exploring how high triglyceride levels can lead to acute pancreatitis, the mechanisms involved, and what this means for diagnosis and treatment. Over the next few slides, I'll guide you through the key points to deepen our understanding of this important topic. Let's get started. Let's walk through a typical clinical scenario to highlight some key points. Imagine a 36-year-old man who struggles with obesity and poorly controlled diabetes. He comes into the emergency room complaining of severe epigastric pain that radiates to his back. This kind of pain is often associated with pancreatic issues, especially pancreatitis. He admits to drinking alcohol the night before, which is an important detail because alcohol can be a trigger for pancreatitis. His lab results show a lipase level over 1,000 units per liter, which strongly suggests pancreatitis. Now, the nurse notices something unusual. His blood sample appears milky. This visual clue can point us toward hyperlipidemia. When we look at his triglyceride levels, they're alarmingly high at 1,800 milligrams per deciliter. This combination of symptoms and lab findings indicates that his severe pancreatitis is likely linked to a hypertriglyceridemia crisis. It's a classic example of how elevated triglycerides can lead to pancreatic inflammation, especially in patients with metabolic risk factors like obesity and diabetes. Understanding this connection underscores the importance of managing lipid levels to prevent such acute episodes. It also highlights why hypertriglyceridemia should always be on our radar when evaluating patients with pancreatitis, particularly if their clinical picture points to metabolic syndrome. Let's look at this clinical scenario involving a 29-year-old woman with PCOS who is on estrogen therapy. She presents suddenly with abdominal pain and vomiting, which can be quite distressing. She denies any alcohol use, so we can likely rule out alcohol-induced pancreatitis here. The CT scan shows an edematous pancreas, indicating inflammation. What's particularly important is her lipid profile, which reveals triglycerides at 2,200 mg/dl, a very high level. Elevated triglycerides like these are a key clue in some cases of pancreatitis, especially when other common causes like alcohol are absent. This scenario highlights how hormonal therapy and lipid abnormalities can interplay to trigger acute pancreatitis. It reminds us that in patients with conditions like PCOS, hormonal treatments can influence lipid levels and potentially contribute to pancreatic inflammation. Understanding these connections helps us better assess and manage patients presenting with acute pancreatitis, especially when typical causes are not evident. Let's look at clinical scenario 3, which I like to call the forgotten fibrate. Here we have a 45-year-old man with familial hypertriglyceridemia who stopped his fibrate medication 2 months ago. Now, he's presenting with acute pancreatitis, which is a serious and painful condition. When we examine his plasma after centrifugation, it forms a creamy layer on top. This is a classic sign of chylomicronemia, indicating extremely high triglyceride levels. This scenario highlights the importance of medication adherence in managing lipid disorders and preventing complications like pancreatitis. It also underscores how abrupt discontinuation of fibrates can lead to dangerous lipid accumulation, reminding us of the vital role these drugs play in controlling triglycerides and maintaining overall cardiovascular health. Let's take a closer look at the mechanism overview. When triglyceride levels go beyond 1,000 milligrams per deciliter, the body's enzyme, pancreatic lipase, kicks into action. It breaks down these triglycerides into free fatty acids, or FFAs. Now, these FFAs are actually quite harmful to the vascular endothelium, which is the lining of our blood vessels. This toxicity can lead to ischemia, meaning reduced blood flow, and can also cause injury to the acinar cells in the pancreas. This cascade of damage results in inflammation and necrosis, which are key features of acute pancreatitis. To simplify this process, high triglycerides lead to an increase in FFAs, which then cause injury to the endothelium. That injury triggers inflammation, and ultimately, this chain of events can lead to pancreatitis. Understanding this mechanism helps us see how severely elevated triglycerides can directly contribute to pancreatic inflammation and injury. Let's take a look at the clinical features commonly seen in this condition. Patients often experience severe epigastric pain that radiates to the back, which can be quite intense and persistent. Along with that, nausea and vomiting are frequent, reflecting the body's response to the underlying inflammation. One of the key diagnostic clues is an elevated serum lipase level, which helps confirm the diagnosis. When you look at the serum sample, it might appear milky or turbid, indicating the presence of lipids or other abnormal substances. It's also important to note that many patients have a history of conditions like diabetes, obesity, or alcohol use. These factors can increase the risk or predispose someone to developing this condition. Understanding these features helps us recognize the condition early and connect these clinical signs with the overall picture we're trying to build in diagnosis and management. Let's take a look at some common triggers that can lead to issues we've been discussing. First up is poorly controlled diabetes. When blood sugar levels are not well managed, it can cause a cascade of problems, including increased risk for certain complications. Next, alcohol abuse is another significant trigger, as excessive drinking can affect various metabolic processes and exacerbate existing conditions. Estrogen therapy, often used for hormonal balance or other health reasons, can also influence the situation, especially in predisposed individuals. Similarly, retinoids, which are commonly used in dermatology for acne treatment, have been linked to certain adverse effects when not properly monitored. Antiretroviral drugs, used in managing HIV, are another factor to consider. While crucial for treatment, they can sometimes contribute to metabolic changes that trigger issues we're focusing on. Lastly, familial hypertriglyceridemia, a genetic condition characterized by high triglyceride levels, is a key familial risk factor that can predispose individuals to these problems. Connecting all these points back to our overall theme, understanding these triggers helps us better anticipate, prevent, and manage the conditions we're aiming to address. Now, let's talk about the management during the acute phase of hypertriglyceridemia. The core of initial management focuses on fluids and pain control. Ensuring the patient is well hydrated and comfortable is essential to stabilize their condition. Next, insulin infusion plays a crucial role because it activates lipoprotein lipase, which helps break down triglycerides rapidly. This intervention can lead to a significant reduction in triglyceride levels quite quickly. In more severe or refractory cases, say when triglycerides exceed 2,000 mg/dl, plasmapheresis might be considered. This procedure can directly remove triglycerides from the bloodstream, providing rapid relief. It's also important to remember what to avoid. Heparin, for instance, should be avoided because it can cause rebound hypertriglyceridemia, which makes the situation worse. Overall, these strategies form the foundation of managing the acute phase effectively, helping to prevent complications like pancreatitis and stabilize the patient. Now, let's talk about long-term management strategies to effectively control this condition. First, maintaining strict glycemic control is essential. This means keeping blood sugar levels within target ranges to prevent complications down the line. Next, it's important to abstain from alcohol, as alcohol can interfere with blood sugar regulation and exacerbate the problem. We also consider initiating fibrates or omega-3 fatty acids, which are helpful in managing lipid levels, especially if triglycerides are elevated. Alongside this, adopting a low-fat diet and working towards weight reduction can make a significant difference in overall management. Finally, it's crucial to manage secondary causes and medications that might contribute to the condition. Addressing these factors helps create a comprehensive approach, ensuring that we're not just treating the symptoms, but also the root causes. These strategies, when combined, support long-term health and help prevent further complications. Let's go over some key pearls to keep in mind. First, when triglyceride levels are greater than 1,000 milligrams per deciliter, that indicates a high-risk situation. It's definitely something we need to be alert about. Now, if triglycerides jump even higher, over 2,000 milligrams per deciliter, the risk of pancreatitis becomes very likely. This is a critical threshold because pancreatitis can be a serious, potentially life-threatening condition. Next, I want to emphasize that insulin plays a dual role here. Besides lowering blood glucose, insulin also helps reduce triglyceride levels. This makes it a very valuable tool in managing patients with severe hypertriglyceridemia, especially when pancreatitis is a concern. And finally, always remember to check the lipid profile in cases of unexplained pancreatitis. Elevated triglycerides can sometimes be the hidden culprit, so a thorough metabolic workup is essential to guide proper treatment and prevent recurrence. These points really tie into the overall theme of managing lipid levels to prevent serious complications. Let's talk about an important note for exams and practice. One classic cause of acute pancreatitis that isn't related to gallstones or alcohol is hypertriglyceridemia. A key clue here is the presence of Milky serum in the blood, which suggests very high triglyceride levels, specifically over 1,000 milligrams per deciliter. Recognizing this can be crucial because it points us toward the right diagnosis. Another vital point to remember is that insulin infusion can be life-saving in these cases. Insulin helps lower triglyceride levels by promoting their uptake and metabolism, so timely administration can really make a difference in patient outcomes. Overall, understanding these clues and interventions is essential, especially when managing patients with unexplained acute pancreatitis. It highlights the importance of considering metabolic causes and acting swiftly to prevent complications.